So without further ado, the first case is going to be presented by Dr. Heather Chen.
Thank you, everyone. Hi, I'll be presenting case 1. This is a 69-year-old male.
Yes. You're actually sharing your presenter notes view rather than the full
I
screen
wanted
view.
to make sure that we are, switch that. How about there? Is that working?
That's great. Thank you so much.
Thank you very much for pointing that out. So once again, this is a 69-year-old male with a past medical history of hypothyroidism and hyperlipidemia. He presented to his cardiologist with increased dyspnea and chest pain on exertion. An EKG was performed and it was unremarkable aside from poor R-wave progression. A stress echocardiogram was also performed and it showed reduced left ventricle ejection fraction at about 35 to 40%. And this was just ruled to be dilated non-ischemic cardiomyopathy. On October 15th, he passed out at home and his wife was able to perform accessible CPR and was then transferred to the hospital. Another echo was performed and his ejection fraction was reduced to 25 to 30%. The coronary arteries appeared to be normal, and so once again, he was diagnosed with non-ischemic cardiomyopathy. His troponin was elevated at almost 10,000, and his BNP was also elevated at 1,000. His chest x-ray was unremarkable. 2 days later, on the 17th, he got an ICD placed. However, the next day, he suffered a second episode of cardiac arrest. CPR was performed and he was able to regain consciousness. He was found to be very hypotensive, and as a result, the cardiology department placed an intra-aortic balloon pump and started a dobutamine norepinephrine drip. He was then transferred to the University of Chicago for ECMO, and luckily a week later received a heart transplant. Here we have a picture of his explanted heart. You can see that there is a mild increase in epicardial fat and that the shape is somewhat globoid. His heart was also enlarged at 478. The average size for a male heart is about 350. The cross-section shows diffuse modeling. Here we have what appears to be somewhat normal cardiac muscle, but there is also some what looks to be damage around diffusely through the heart. On histology, we can see that there is a stark infiltrate of inflammatory cells percolating through the cardiac myocytes. On higher power, the most prominent inflammatory cells are the giant cells. You can also see some of the giant cells are consuming the cardiac myocytes. Some of the other components of this inflammatory infiltrate are monocytes, along with lymphocytes and eosinophils. Here is a picture showing all the elements I have described, such as the giant cells, monocytes, lymphocytes, eosinophils, and damaged cardiac myocytes. So now I'll pause for a discussion.
So hi, this is Michael Pins. Welcome everybody. So differential diagnosis, really a striking infiltrate. With the histology we just saw mixed inflammatory, some giant cells. Please feel free to chime in with differential diagnoses. I'm getting some texts, giant cell myocarditis, fulminant lymphocytic myocarditis, cardiac sarcoid are 3 things that were mentioned. Anybody have any other differential diagnoses? Yeah, I think certainly giant cell myocarditis is at the top of the list, but you know, this is a guy with a history of other you know, hypothyroidism, hyperlipidemia, et cetera. Is he on meds? And there is a significant eosinophilic component. So one thing I put way down on the list was you know, an iatrogenic hypersensitivity myocarditis. Certainly other granulomatous myocarditis are in the differential. A couple of other things that are popping up on the chat include COVID-related giant cell myocarditis. Obviously, some additional testing will be insightful for that. Any other thoughts? Okay, without further ado, oh, there's Rosie Dorfman just popped up. So without further ado, why don't we continue?
All right, well, thank you very much for this discussion. It was great. So a lot of things on our differential diagnosis were touched upon in the diagnosis and the discussion. So we have to think about two different, branches of cardiac disease. So myocarditis and granulomatous diseases. So in the myocarditis branch, there are three main diagnoses that we need to think of, such as giant cell, fulminant lymphocytic myocarditis, and also eosinophilic myocarditis. So in this case, the predominant inflammatory component is giant cell, though if you got a biopsy and you just got mostly the eosinophilic portion, I can see how one could be thinking eosinophilic myocarditis. In granulomatous diseases, we have to be thinking whether these granulomas are non-caseating or caseating. If it's caseating, which we don't see caseating granulomas in this case, we have to think of infections such as TB or fungemia. For non-caseating granulomatous diseases, we really are thinking of giant cell myocarditis and cardiac sarcoidosis. COVID is a great idea. This person was not positive for COVID, so that wasn't really on our differential. And Rosai-Dorfman is also a great idea too, that we did not include our differential diagnosis, but looking at the type of inflammatory cells that were there, definitely would want to add that to my list in the future. So in this case, we're really thinking of, is this giant cell myocarditis or is this cardiac sarcoidosis? And the importance of making this diagnosis is that giant cell myocarditis progresses to heart failure much more rapidly than cardiac sarcoidosis. So there's an urgent need to transplant these patients. Whereas cardiac sarcoidosis, it's more of a chronic heart failure disease. So you can manage that a little less, with less expediency. Here is a diagram and a table illustrating the two entities and the differences between the two. So we'll think of inflammation, myocyte necrosis, granulomas, and fibrosis. For inflammation, both of them can have giant cells and lymphocytes in their inflammatory infiltrates, but giant cell myocarditis will really have a diffuse inflammatory infiltrate or multifocal, whereas cardiac sarcoidosis inflammation will be much more limited. For myocyte necrosis, it will be absent in cardiac sarcoidosis and present in giant cell myocarditis. The granulomas are more common and better formed in cardiac sarcoidosis than in giant cell myocarditis. And fibrosis you will see in cardiac sarcoidosis, but not in giant cell myocarditis. So taking all these elements together, we'll think again about what this diagnosis is, and I'll show you some IHCs. So the desmin here, we have on the blue arrow side, some normal looking cardiac myocytes, but on the red arrow side, you can see that there's some damaged cardiac myocytes. Here on a higher power, you can see that these cardiac myocytes are ragged and torn apart, and there's a lot of inflammatory cells infiltrating in between them, with a giant cell hiding up in this corner. The C4D is helpful to look for ischemia. In that case, the staining will be strikingly and strongly brown, whereas in this case, you can see there is a gradient indicating there's a gradient of damage for the cardiac myocytes. Down here, we see there's some giant cells. And here I have a picture of what the C4D would look like if this was used for myocyte ischemia. And you can see, comparing the two, we don't really see the same strong brown diffuse cytoplasmic staining. And here's another picture really illustrating the gradient of damage of the cardiac myocytes. A CD68 highlights both the multinucleated giant cells and the monocytes. So you can see that, while the multinucleated giant cells on the H&E is very striking, there is actually quite a bit of monocytes admixed in this inflammation. And here's a higher power look where there are some giant cells and lymphocytes and monocytes. The lymphocytes are mostly T cells as highlighted by this CD3. And there are rare B cells as highlighted by the CD20. For what types of T cells they look to be mostly CD8 positive T cells as shown in this picture. The CD4 has a lot of background staining, but the number of lymphocytes that were stained by CD4 is much less than the number of lymphocytes that were stained by CD8. So this was a giant cell myocarditis as we diagnosed. So I'll talk about some of the features of this entity. The pathogenesis is currently not fully known. A lot of studies have surmise this is most likely due to immune dysregulation by T lymphocytes, and there's a genetic predisposition. And most likely this is because there's an upregulation of genes involved in a Th1 pathway. Rat models have shown that giant cell myocarditis is induced by autoimmunization of cardiac myosin. Rarely this has been reported to be associated with some drug hypersensitivity and infection, mostly viral things, but this is not shown to be consistent. So most likely this might be coincidental versus causation. The incidence of this is very low. Autopsy studies have shown this is anywhere between basically less than 0.1% to even less than that. And it affects mostly healthy, young to middle-aged adults. It can affect some young children and elderly, and there is no sex predilection. The clinical features for a patient is that they present with rapid onset congestive heart failure, ventricular tachycardia, and some symptoms similar to acute myocardial infarction. And the median time of onset is very rapid, about 3 weeks. It also is associated with autoimmune disorders, which makes sense given the pathogenesis that we are surmising. On histology, we will see multifocal or diffuse inflammatory cell infiltrates. These will be mostly multinucleated giant cells and some macrophages that are CD68 positive. There will also be mostly T lymphocytes and some plasma cells and some eosinophils. We will also see prominent myocyte damage that will be disproportionate to the granulomatous inflammation. You can also see poorly formed non-necrotizing granulomas. And interestingly enough, there have been case reports documenting giant cell myocarditis limited to just the ventricles or just the atria. We actually have a case in-house of a giant cell myocarditis that incidentally was involving the atrial appendage. And we can see some of the features that we have seen in our previous case here. The prognosis without therapy is very dismal. The median survival from onset to death is 3 months. With therapy and no transplant, the 5-year survival rate increases to about 52 to 72%. With therapy and a transplant, the 5-year survival rate is even better at 71%. So the treatment is long-term heavy dose immunosuppressive. So typically a combination of either cyclosporine, mycophenolate, or corticosteroids. Unfortunately, the immunosuppressives do not prevent the development of arrhythmias. And transplant is really one of the thing that we need to perform in these patients in order to have a definitive treatment. The follow-up for our patient is he got his transplant. We did some surveillance biopsies. The first biopsy he had, there's no evidence of acute cellular rejection, which is great. But 2 weeks later, we also saw the same thing, no evidence of acute cellular rejection. And in one section, we saw this. And looking closer, we have a giant cell here and some eosinophils and lymphocytes, kind of going in between cardiac myocytes. So unfortunately for this patient, this was a recurrence of giant cell myocarditis. And in recurrent diseases and transplant hearts, giant cell myocarditis is one of them, along with sarcoidosis and amyloid. In giant cell myocarditis, the recurrence occurs in about 20% of transplants, and they can occur concurrently with acute cellular rejection. But luckily, the long-term survival is not impacted, and the thought is that it's because they already are on high-dose immunosuppressives due to their heart transplant. So since steroids treat both giant cell myocarditis and is also part of therapy for transplanted hearts, it kind of helps with mitigating the effects of giant cell myocarditis. Cardiac sarcoidosis can also recur in a transplanted heart. It's not as common. It's mostly been documented in case reports. And similar to giant cell myocarditis, because of the steroids, the long-term survival is not impacted. Amyloid is a disease entity we did not discuss in our differential since there are not really any features that would suggest amyloidosis, but it is a disease that does recur in transplanted hearts. Most of these cases have been reported with AL amyloidosis, which is also the most common type of amyloidosis there is. And the survival rates are not great. 2 years post-transplant, the survival rate is 60%, and 5 years post-transplant, the survival rate is 30%. As of today, though, the patient's immunosuppressive dose was increased, and 8 subsequent biopsies showed no rejection and no recurrence of giant cell myocarditis. And so the patient is doing quite well. These are my references. And then I leave you here with any questions.
Yeah, thank you, Heather. Terrific presentation. Really striking example. I'm curious, you mentioned the association with autoimmune disease. The cause of this patient's hypothyroidism, is it Hashimoto's? Do we know that?
No, it's not due to Hashimoto. So I think in this case, it's not associated with autoimmune disease. So, he tends to be a larger patient. So he had hyperlipidemia and was a larger guy in general. But no, so he didn't have Hashimoto's basically.
Okay, and I just want to, if I can, I was a cardiovascular pathologist in my previous life, and I just want to reinforce a point that you made about how aggressive this can be. And I've seen over the years a couple of endomyocardial biopsies that had giant cell myocarditis on it, and we occasionally get clinicians that are a little bit reticent about initiating some sort of a therapy or being aggressive because the infectious workup hasn't been completed. And I think it's kind of up to us to reinforce to our clinical colleagues when we do see on endomyocardial biopsy changes suggestive of giant cell myocarditis that this is important, this is significant, and maybe is a lesion that shouldn't be sat on.
Yeah.
I just want to reinforce that point.
Mike, this is Vinay.
Yeah.
Okay, Heather, great. I think one of the things that everyone should be thinking about in adding to the cause of myocarditis of the kind you described is patients who are receiving checkpoint inhibitor therapies for cancer. Myocarditis is a complication of those.
All right, well, thank you. Yeah, and it's definitely something that we can add when you're thinking more broadly. In this case, this patient wasn't on any checkpoint inhibitors, but if, in someone's clinical history they are, you would definitely have to think about that. That is a well-known issue. Measure
the pituitary, of the thyroid, of the heart, in multiple organs, inflammatory response can occur.
Yes. Yeah. So we have seen that myocarditis after checkpoint inhibitors, but it tends to be lymphocytic and maybe some histiocytes. But I don't think I've ever seen giant cell myocarditis in response to that yet. Okay. But who knows?
Yes, it's still too early to tell. All right.
Heather, you also said something about Th1 dysregulation. Anything more specific than that?
I don't know, honestly. I mean, unfortunately, the pathogenesis is still being worked out, so I don't know exactly all the details for that, but I can take a look and send you.
But I think it's correct to say that what you see appears to be a Th1 response.
Yeah, that's what mostly it seems to be. It appears to be a Th1 mediated, but like how that is.
Right. Were there also neutrophils in any significant component?
No, not really, honestly. And we didn't really see any plasma cells either. In this case, it was mostly like the giant cells, monocytes, eosinophils, and lymphocytes.
So I think another thing to keep in mind is this, that if you see neutrophils as well as lymphocytes, there will be a Th1 and Th17 response. Th17 actually in the cytokine IL-17 is a chemotactic factor for neutrophils.
I don't think there were any significant neutrophils in this case.
Yeah, there really wasn't in this case. Yeah.
Yeah, I'm in a conference. Can I call you back? Okay. Yeah, so in the interest of time, why don't we move on to the next case? Again, terrific case.
All right, thank you very much. So I will be presenting Kristina Dojcheva, and she'll be presenting case number 2. Thank you.
Good afternoon. Thank you for joining us for this talk today. I'm gonna start my case. And this is a 34-year-old female with past medical history significant only for symptomatic uterine fibroids. Upper abdomen and pelvic imaging revealed an enlarged uterus measuring 17.1 centimeter in greatest dimension with hypervascular lesions likely representing fibroids. She did undergo hysterectomy and bilateral salpingectomy, and gross examination of the specimen revealed multiple well-defined white whorled myometrial nodules ranging in size between 2.3 and 8.0 centimeter in greatest dimension. And this is an example of one of those nicely circumscribed white nodules. On histology, we identified a hypercellular smooth muscle tumor with numerous dilated or ectatic thin-walled blood vessels, in addition to some staghorn blood vessels represented in this field. Further, there were multiple areas with alveolar type edema, as you see right here and here. In addition, there were a lot of bizarre hyperchromatic nuclei. And on high power, we appreciated a eosinophilic globoid cytoplasm represented in this field, as well as macronuclei that were eosinophilic to cherry red, with perinucleolar or clearing also can be considered as a halo. So in summary, we have a cellular smooth muscle tumor with staghorn blood vessels, cytoplasmic eosinophilic globules, bizarre nuclei, perinucleolar halos or clearing, and prominent eosinophilic macronucleoli. Of note, there was no necrosis, and we did not appreciate any mitosis in this entity. So at this time, I'd like to offer some time for a potential differential diagnosis.
Yeah, so differential diagnosis on this. Very smooth muscle-ish on the slide that was sent out, but the histology we're shown is just as beautiful and makes you think of, I think, an fumarate hydrase deficient Lyomyoma. You know, that they've used the term alveolar kind of edema. Pretty sure it's that entity, but it's not a great descriptive term, but that edema that we showed would fit for that. And I think some of the cytologic features would fit for that. Any other thoughts on in the chat box on this differential diagnosis? Yeah, I also didn't appreciate a lot of mitoses and no tumoral type necrosis. One of the things I think is always important to ask whenever we see these funny uterine stromal tumors or smooth muscle appearing tumors is whether the patient was on some sort of intervention to help shrink them, because I think it really impacts the histology that we see. We're often not given that history, and I think it does impact the what we see on the slide. So that's important history. I don't know if this patient was on any kind of agent to help shrink those symptomatic fibroids or not, but
no, she did not have any treatments or interject.
Okay. So, you know, Lyomyoma, Lyomyoma variant, Leiomyosarcoma, probably farther down the list, but I think FH deficient Lyomyoma has to be in the differential diagnosis. As far as some incoming differentials, staghorn or staghorn vessels, SFT was mentioned, but I think that's a pretty good differential. So Heather, yeah, or no, I'm sorry, you're not Heather.
That's okay. No,
Yeah.
that's all right, Christina.
You're showing up as Heather. I'm sorry.
It's all right. All right. Thank you very much. I appreciate that differential. And you guys listed pretty much all of the things that we thought of. And first, we're going to start out with a leiomyosarcoma, as this is the reproductive tract of a female. And how do we diagnose leiomyosarcoma? That is where we should be able to identify marked cytologic atypia, tumor cell necrosis, and 10 or more mitosis per 10 high power field. As mentioned earlier, we did not see tumor cell necrosis or mitosis, so we ruled out the leiomyosarcoma from the differential. Next is smooth muscle tumor of uncertain malignant potential. And this entity falls on the spectrum between leiomyoma and leiomyosarcoma, and there's really no strict criteria for the diagnosis, but the WHO recommends that we consider one of the following, and that is focal to multifocal or diffuse nuclear atypia with 6 to 9 mitoses per 10 high power field, but there should be no tumor cell necrosis. If tumor cell necrosis is identified, then there should be no other worrisome features, as we would fall in the category of leiomyosarcoma. And if there's 15 or more mitoses per 10 high power field, there should be no other cytological atypia or necrosis. And for us juniors, we have to be on the lookout always for the brisk prominent karyorrhexis that occurs in this entity. And we should definitely not count it towards diffuse nuclear atypia or the mitotic count. So we did not see any of these features, therefore we ruled out diagnosis from the differential. And moving on to leiomyoma, and specifically 3 subtypes that we're going to discuss is hydropic, bizarre nuclei, and fumarate hydratase deficient leiomyoma. First is the hydropic leiomyoma, and what's unique in this entity is that it has a zonal water edema represented right here, that separates the tumor cells into very delicate, thin cords or nests. Although we did have edema, it was more of the alveolar type rather than the zonal. So we can rule out this from the differential. Next is Lyomyoma with bizarre nuclei. And this entity is identified by staghorn, blood vessels, alveolar pattern of edema. We can have mononucleated and multinucleated bizarre nuclei that have smudged chromatin. Of course, we can have the brisk karyorectic nuclei, and definitely the eosinophilic globular cytoplasm. So at this time, you might be saying, well, we checked off all of the boxes and probably this is the diagnosis, but I implore you not to anchor yourself yet and explore the last entity, and that is fumarate hydratase deficient Lyomyoma. And many of you know probably that this entity, Lyomyoma with bizarre nuclei and fumarate hydratase deficient Lyomyoma, do share some histomorphological characteristics. But this, the FHD deficient Lyomyoma truly does not, on immunohistochemistry, most of the cases will have a loss of the enzyme. And this is the IHC that we did on one of our slides. As you can tell, the smooth muscle tumor cells are not expressing and not picking up any, not even a blush of the IHC. The only cells that are highlighted are the endothelial cells of the blood vessels. So the most likely diagnosis at this time, we decided is fumarate hydratase deficient Lyomyoma. And before we kind of discuss what we did with our patient, I want us to go back and remember our days from med school where we had to learn all about the Krebs cycle. And this will help us understand why fumarate hydratase enzyme is important in this development of this entity. And it is fumarate hydratase converts fumarate into malate. And once we have some type of a mutation, be it somatic or germline, fumarate builds up into the mitochondria, or the nuclei of a cell, and spills into the cytoplasm, which in turn starts to exert a lot of effects on protein. So mentioning the germline and somatic mutations, we're more interested in the germline mutation as it is implicated in the hereditary Lyomyomatosis and renal cell carcinoma syndrome. This syndrome is inherited in an autosomal dominant fashion, and patients are predisposed to developing cutaneous lyomyomas, uterine lyomyomas, and aggressive renal cell carcinoma type. The uterine lyomyomas are usually identified at an average age of 28, and most women undergo some type of either myomectomy or a total hysterectomy in their 30s. Now, regarding the renal cell carcinoma, approximately 15% of patients with this syndrome develop this aggressive renal cell carcinoma type, and the average age of diagnosis is around 36. So if we're able to morphologically identify an FH deficient Lyomyoma approximately a decade earlier, prior to the diagnosis of a very aggressive renal cell carcinoma, we can suggest genetic counseling and testing and start a chain where the patient can be triaged and managed appropriately. Some of you might be interested in the IHCs. There really a role for IHC in this entity, and Elizabeth Chan and her group identified 6 cases that had morphology and histology similar to FHD. All cases were either myomectomies or hysterectomies. They obtained multiple sections and stained them with the FH-IHC. As you can tell, the result is a little bit scattered. We have only 1 case that had showed complete loss. 3 cases showed heterogeneous expression, and 2 cases had complete retention of the expression. So what does that mean for us? A complete loss of the FH enzyme can be helpful in the diagnosis. But if we have retention of expression, we have to keep in mind that the FH gene can harbor a missense mutation that can still allow for the production of a protein, but that protein will be not functioning. And thus it will still be picked up by the IHC. So just because we don't have complete loss of expression of the FH enzyme, that does not mean that we can rule out the diagnosis. So back to our patient, we did suggest that she undergo genetic counseling and testing, and she did. This is her pedigree. Right here at 34, she underwent total hysterectomy for lyomyomas. As you can tell, her mother had some kind of a renal tumor with metastases that was diagnosed at the age of 54. And there are other family members that underwent hysterectomies due to fibroids. Her germline testing revealed a fumarate hydratase variant of uncertain significance, and somatic testing did not reveal any additional mutations or copy number alterations. She has opted in for to undergo renal ultrasound screening yearly as a preventative measure. So summary and take-home points, it's important to be able to identify the morphological features of FHD. And how do we do that? On low power, we look for staghorn blood vessels and alveolar pattern of edema. And at high power, we should be screening for cytoplasmic eosinophilic globules, prominent macronucleoli with perinucleolar halos, and we may or may not see bizarre nuclei. And of course, why is it important? By being able to identify these entities, we can avoid the overdiagnosis of stump and leiomyosarcoma, but also it allows us to recommend genetic counseling to evaluate for the syndrome. So at this time, I'd like to welcome any questions that you guys have.
Yeah, any questions? So a couple of the questions I think have already been answered, the questions I'm seeing on chat. Any other questions?
Yeah, I have a question, and that is, I believe that...
Hi, I have a question. Any skin lesions?
The skin lesions are...
Did she have any skin lesions?
She did not this lady, no. There were no cutaneous leiomyomas that we know of.
Sorry.
That's all right.
So as you probably know that leiomyomas have a fair number of chromosomal abnormalities.
Right. So please go.
You know, there are monosomies, there are monosomy 22, and some trisomies, and certain, I think, 12, 14 translocations. Any knowledge in the literature about such chromosomal abnormalities in leiomyomas of this particular type?
So not specifically for the type, but the HLRCC syndrome, pretty much the mutation is on chromosome 1, its long arm, but nothing that I know of that is specifically pinpointed as a mutation within a gene or within a chromosome.
Okay.
Any other questions or comments?
I'm sorry, I'm not sure whether my question went through. I was on the phone. Did the patient have any skin lesions? Because majority of patients have skin lesions.
Right, and about 75% of patients with this syndrome do have cutaneous leiomyomas. We're not aware of that she had any. Her chart did not state that she did. Whether or not, maybe she has something, but she's never brought it up to a physician's attention.
Mm-hmm. Okay, yeah. Thank you.
Okay, Christina, if you could introduce the next speaker, that'd be great.
Thanks. Yeah, with pleasure. I'd like to introduce Dr. Jasmine Zikri.
Okay. All right, thank you everyone, and thank you, Christina. So I will be presenting case number 3, which is beginning with a breast biopsy. So our case is that of a 36-year-old female. She has a medical history of fibromyalgia, polycystic ovarian syndrome, and tobacco use. Her surgical history is significant for a bilateral breast reduction in 2012, an excision of a right breast fibroepithelial lesion in 2016. She presented with a new self-palpated right breast mass right at the site of her previous lesion excision. And this mass was biopsied at an outside hospital in 2020. So I will now show you this specimen. It is a pleomorphic neoplasm that is focally necrotic. And in this core biopsy, it's important to know that there is no recognizable background breast parenchyma. Again, it is a pleomorphic neoplasm that is focally necrotic. The cells have enlarged hyperchromatic nuclei, but they also have abundant cytoplasm that is eosinophilic to optically clear and vacuolated. And there are multiple mitotic figures that are readily apparent in this field. To further characterize the lesion, immunohistochemical studies were performed, and it showed that the lesion was focally positive for AE1, AE3, but negative for other cytokeratins such as CAM 5.2. Also, the lesion was focally positive for P63, and the negative stains that were performed are listed here. Because the patient desired further medical management at the University of Chicago, the remainder of her prior pathologic specimens were requested for in-house review. So now I'm going to show her right breast lumpectomy specimen that was performed in 2016. We have a mass protruding into a cavitary space, and it is surrounded by normal background breast parenchyma and stroma and fat. The stroma of the mass had a light blue tinged myxoid background. It had delicate, thin vasculature and stromal cells that have high NC ratios. And then in the bottom of this field, there is no readily apparent epithelium covering this protruding mass. Other areas showed adipocytes of varying size and shape, and some had enlarged hyperchromatic nuclei, which we can compare to the background percolating lymphocytes. So now that we have reviewed all of the patient's prior pathologic specimens, she is at University of Chicago and she desires further medical management of her self-palpated right breast mass, and she desired surgical resection, which prompted preoperative imaging. In the preoperative imaging, we can see a lobulated mass that was seen on mammogram, and on ultrasound, there was a mixed hyper and hypoechoic mass that was ill-defined. PET scan showed avidity of the right breast, and there was no uptake anywhere else suggestive of metastases. Grossly, the resection specimen, there was a large lesion which was solitary, firm, white tan, and rubbery. And it was, in this portion, we can see a solid component, and then on the left-hand side, it had more of a vaguely lobulated architecture with some areas that appeared more translucent and gelatinous, and the remainder of the background breast parenchyma had no further lesions. Microscopically, the lesion was very heterogeneous. So here we can see basophilic areas of densely packed cells against the more optically clear adipocytic areas. And there are thin eosinophilic fibrous septae that intervene through the specimen. Evaluating some of these areas, so it had an interesting architecture of finger-like projections protruding into a cavitary space, and then there was a thin layer of epithelium lining these projections. There were areas that were very similar to the lumpectomy specimen with myxoid stroma and adipocytes of various sizes. Other areas showed a predominance of lipoblasts that have their multivacuolated cytoplasm and scalloped nuclei. Another area showed more of a pleomorphic appearing component similar to the first biopsy that we looked at that showed marked nuclear variation in size, atypical mitotic figures, and some nuclei have prominent nucleoli and abundant eosinophilic cytoplasm. For the immunohistochemistry that was performed on the resection specimen to further characterize it, it was again focally positive for P63, but it was negative for all cytokeratins, including AE1, AE3, and CK56, and it was negative for CD34. So I will now pause for the differential diagnosis.
So differential diagnosis on this, beautiful H&E sections. We're seeing lipoblasts, we're seeing more solid areas. Boy, that gross with the bright yellow areas, the tan yellow and the varying shades of yellow. That in the retroperitoneum, you'd think of a dedifferentiated liposarc, right? But this is obviously breast, so that gross was just beautiful. We've got a couple of differentials coming in, one of which is malignant Fluidities with heterologous differentiation. I think the term that the WHO uses is Liposarcomatous Fluidities tumor, I think is the term that they use for that. Yeah, certainly with that Fluidities-like growth pattern, that has to be way up there. I think the differential has to include a non-breast primary, a primary dedifferentiated liposarc, much less common, but I think that has to be in the differential. It's interesting, the outside report was of at least focal AE13 positivity. Current material is negative for cytokeratins, but I think metaplastic carcinoma has to be in the back of our minds. This would be an unusual spindle cell or sarcomatous component to a metaplastic carcinoma, but I think that has to be in the differential. Did anybody have anything else? Any other things in their differential?
Hello, Dr. Pins. This is Ishmael. I was thinking about primary myxoid liposarcoma as well. Okay. I know it's pretty rare in the breast, but I think it has the round cell and it has the myxoid background, so that was one of the differentials that I was thinking about.
Yeah. I think one diagnostic that would be helpful would be MDM2 amplification, obviously by FISH or perhaps by IHC. Okay.
All right. Well, thank you everyone for your differential. You really hit the nail on the head. So far, our differential includes malignant Fluidities, liposarcoma, including various types such as myxoid, well-differentiated, dedifferentiated, and pleomorphic, and as well as sarcomatoid carcinoma, or as you called it, metaplastic carcinoma. So overall, given this differential and given the architectural features, the cellular morphology, and the immunohistochemistry, our patient's lesion was felt to be most consistent with malignant Fluidities with heterologous liposarcomatous differentiation. So what is this tumor? So heterologous sarcomatous elements can be seen in up to 20% of cases, and any type of sarcomatous element can be seen in malignant Fluidities, with adipocytic differentiation being the most common and being present in approximately 7%. All cases to date have been in females with a mean age of 48 years and were unilateral. For the gross, thank you for complimenting my gross image. So grossly, tumors are typically well circumscribed and they appear deep yellow in the well-differentiated mature adipocytic components and can appear more lucent and gelatinous in pleomorphic or myxoid areas. Microscopically, there are the broad leaf-like epithelial and stromal formations that are characteristic of Fluidities tumors. And the malignant adipocytic component has a wide range of morphology, essentially identical to that seen in soft tissue sarcomas. And this can include well-differentiated, myxoid, dedifferentiated, round cell, and or pleomorphic, and multiple different morphologies can be present in the same tumor. And it's important to note that although they are both liposarcoma and malignant Fluidities are mesenchymal tumors, a concurrent malignant epithelial component is rarely identified. So for immunohistochemistry, cytokeratin markers are typically negative, but may be focal and weak, and it can be a significant pitfall, especially on small biopsies, and it was focally positive in our patient's biopsy that we first received. And CD34 and S100 are variable and may be focally positive. Desmond, ER, BCL2, and smooth muscle actin are negative. So for the molecular of malignant Fluidities with heterologous liposarcoma, so MDM2 and CDK4, which you alluded to, amplification is seen in 90% of well-differentiated and dedifferentiated liposarcoma, including those that occur primarily in the breast. However, malignant Fluidities with heterologous liposarcoma lacks immunostaining for MDM2 or CDK4 and lacks the FISH amplification of MDM2. Also, no recurrent chromosomal aberrations have been described in malignant Fluidities tumor with heterologous liposarcoma. We did perform MDM2 CDK4 immunohistochemistry in our patient, and both were negative. We also did perform the FISH for MDM2, which indicated no amplification. Interestingly, however, we did perform next generation sequencing, which showed a BRCA2 rearrangement involving exon 11 and an FBXW7 substitution mutation. So to further evaluate the molecular results in our patient, BRCA2 is a tumor suppressor gene present on chromosome 13. BRCA2 alterations have been detected in Fluidities tumors with distant metastases. It's also important to note that BRCA2 germline mutations predispose patients to both breast and ovarian cancer. However, those mutations are typically deletions and insertions which cause frame shifts, and this is different than the rearrangement mutation which we saw in our patient. FBXW7 is an E3 ubiquitin ligase, and alterations have been described in both sarcomas and in Fluidities tumors, but is very rare. So for treatment and prognosis of these lesions, wide surgical excision is the mainstay of therapy. The overall recurrence rate is approximately 14%, and features that incur a higher risk of recurrence are a pleomorphic liposarcomatous component and the presence of microscopic infiltrative growth margins. And these lesions may become higher grade on local recurrence. So just like its soft tissue counterparts, the histologic features are very important for prognosis and appear to be a significant biologic driver. So for the patients who have a well-differentiated component, they have a much better clinical course than those who have pleomorphic liposarcomatous components. When metastases do occur, they're typically hematogenous, and lymph node metastases have been described but are very rare. To follow up on our patient, she now has completed neoadjuvant radiation therapy to the chest wall and is doing well with no evidence of metastases or recurrence. And these are my references. So I will now take any questions.
So Jasmine, I'm curious how this would be signed out. So would it be signed out as Fluidities tumor with heterologous, parentheses, liposarcomatous or dedifferentiated liposarcomatous elements? I'm curious exactly how would you word this sign out?
Yeah, so the WHO in the malignant Fluidities tumor does have a descriptive term, and that's what I use, the malignant Fluidities tumors with heterologous liposarcoma. I think it was officially signed out as malignant Fluidities tumor with heterologous liposarcomatous differentiation.
Okay, so really not so the term dedifferentiated liposarc wouldn't necessarily be part of the sign out then?
We were descriptive about what we saw, but that was not the main overarching term that we used.
Okay. Any other questions or comments on this case? Yeah, very nice case. Okay. Yeah, Jasmine, if you could introduce the next speaker.
Sure thing. Thank you so much. So our next speaker is going to be Dr. Tanner Storzuk.
Hi, everyone. Can you see me okay? Sorry. Okay, so yes, indeed, I'm Tanner Storzuk, and I'll be presenting case number 4 today of a case of a screening colonoscopy. So for a bit of history and presentation, we have a 60-year-old female here presenting for a routine screening colonoscopy. She had primarily been receiving her routine annual gynecologic examinations for a history of atypical squamous cells of undetermined significance. She has a pertinent past medical history that includes a left breast partial mastectomy for invasive ductal carcinoma and a skin excision for angiokeratoma. She had previously had a colonoscopy 10 years ago at age 50. So this is what they saw on colonoscopy. They identified 10 polyps. They had identified 1 5-millimeter sessile polyp in the ascending colon, 8 small semi-pedunculated polyps in both the transverse and descending colon, as well as 1 5-millimeter sessile polyp in the sigmoid colon. Histologically, this is a look at 6 polyps, and we're going to be focusing on 2 of them specifically. So at low power here, we can sort of see these vacuolated, cleared out spaces, and we're going to be focusing on those. We go a little bit higher power, and what we can see is that we have what appears to be adipose tissue sitting directly above here. If I can get the mouse to work, the muscularis mucosa. So one thought would be, is this air insufflation or is this true adipose tissue? And the way we sort of can tease this out is by using immunohistochemistry. S100 highlights adipocytes, they're with membranous staining, and the lamina propria shows dendritic cells that also stain with S100. So these serve as sort of a positive internal control. Now looking at the second polyp, just at low power here, we notice again in the lamina propria, it sort of has this more eosinophilic appearance. And by focusing a little bit more closely on higher power, we can see almost this proliferation of spindle cells within the stroma. So at this point, I would sort of like to break for thoughts on what is going on with this patient.
So I'm sure the S100 was also performed on the spindle cell elements in the lamina propria that you showed. So that'll be interesting, see if they're neurogenic. So differential diagnosis, first blush without any history, I might have just called them hyperplastic polyps, but obviously a little more going on than that. They're now looking a little more hamartomatous, and I'll be interested in the S100 in that spindle cell area that we saw. Is there a ganglia or neuromatous component to these hamartomatous polyps? Do we have a unifying diagnosis, though, between the history of high-grade breast cancer and the current multiple polyps? There are a couple of syndromes. Cowden obviously comes to mind. Putz-Jaeger's would come to mind. The skin lesion is interesting. We often get these history of skin lesions that are signed out descriptively and such, non-specific. This was, I think, signed out as an angiokeratoma. So that may be part of the constellation of findings. So sounds syndromic, something in the hamartoma family. Cowden, Putz-Jaeger, perhaps something else. Any other thoughts by anybody? Yeah, there's a couple that are popping up. Lee-Frau-Meny is one. Most of those are P53 related. This is more of a hamartomatous polyp, but yeah, something syndromic. So Tanner, I think that's pretty good differential.
Just to follow up, S100 was performed on that second polyp as well, but was negative. Exactly, you guys touched on everything. Definitely something you want to think along the lines of something syndromic in a patient that has now 10 polyps and sort of has this history as well. So I just wanted to summarize the key points of this case. So we had a 60-year-old female that was here for a screening colonoscopy. She has a history of breast cancer and angiokeratoma. Now she's presenting with colonoscopic removal of numerous intramucosal lipomas and nondescript prolapse-like polyps with fibrous-rich stroma. That's how these 2 polyps had been signed out. However, these are indeed hamartomatous polyps, as was pointed out. So I'd like to sort of summarize a bit about the diagnostic criteria of Cowden. So using the clinical data on the right side of the screen here, you can see that the diagnosis of Cowden syndrome is broken down into major and minor criteria. So in our patient's case, with a history of breast cancer, gastrointestinal hamartomas, and the angiokeratoma fitting in the vascular anomaly family, we made the suggestion that this patient should undergo genetic screening for a P10 mutation. She did not have a family history of a P10 mutation, and her family history was relatively unremarkable, but just considering that she did have 2 major criteria and this minor criteria, we made the suggestion that the clinical team evaluate her in this circumstance. So just to follow up, various scoring systems exist to predict the likelihood that a patient will actually have a P10 mutation based on the criteria I've just shown. And this is an example of the Cleveland Clinic's scoring calculator, whereby if we input the patient's clinical data, what we can see is in this case, we focus on the head circumference, her history of breast cancer, the vascular malformations, the number of polyps that she had, as well as the fact that they are hamartomatous polyps. And it actually indicated she had a pretest probability of having a PTEN mutation of 82%. So, and looking forward, she had with a personal history that was suspicious for Cowden syndrome and this high pretest probability, she consented to undergo genetic testing. However, despite this high pretest probability, there was no PTEN mutation identified. PTEN mutations are only seen in 25 to 35% of Cowden syndrome patients, however. So a little bit more on Cowden syndrome. It's also known as the PTEN hamartoma tumor syndrome. There's an increased risk of benign and malignant tumors of the breast, thyroid, endometrium, GI tract, and kidney. And it has a prevalence of 1 in 200 to 250,000 people, with males and females equally affected due to its autosomal dominance inheritance pattern. So to emphasize the importance of the diagnosis, we as pathologists have an essential role in actually suggesting Cowden syndrome. Oftentimes we sort of get this history and we have these findings and we're left to sort of piece it all together. And it's important that we make this diagnosis to enroll both the patient, siblings, and offspring in appropriate cancer screening. And as you can see with the image on the right, I've highlighted the breast. The 12% there represents the lifetime risk of the general population of developing cancer at this site, whereas the 85% in red represents the average risk of a Cowden syndrome patient at developing cancer of the breast. So moving forward, these are the pathognomonic manifestations in the GI tract of Cowden syndrome. So when we typically think of Cowden's, most commonly thought about is esophageal glycogenic acanthosis.
183.
As well as colonic ganglioneuromas. These entities on their own are relatively non-specific. However, once again, if we can put the whole clinical history together and we're aware of other things going on and have a good history of a patient, we can sort of start thinking along the lines of, could this be fitting into a certain syndrome? And to follow up on this, there was a 2017 paper that looked at the intramucosal lipomas of the colon and how they implicate Cowden syndrome. Intramucosal lipomas are commonly missed, yet diagnostically significant finding in Cowden syndrome patients. And this study looked at 25 cases of intramucosal lipomas that, similar in our case, we used S100 immunohistochemistry to confirm that these are indeed adipocytes within the polyp and not pseudolipomatosis, sort of an artifact of the procedure. And here is a table of what they found. The first 5 cases on the top here represent cases of true Cowden syndrome patients. Within those, 4 of the 5 cases they identified actually had PTEN mutations. Below that represents 3 cases of possible Cowden syndrome where they were either not tested for a PTEN mutation or they didn't quite fit a clinical presentation. It was maybe suspicious for it. And the other 17 cases outlined represent cases that are just sporadic intramucosal lipomas. And endoscopically, what they found is that the cases of Cowden syndrome actually, the number of polyps ranged from 30 to 100 within these patients. So markedly, a marked number of polyps were found in these Cowden syndrome patients. So this paper went on to actually suggest that intramucosal lipoma on its own in the context of other GI hamartomatous polyps or breast cancer can sort of present this history that's highly suggestive of Cowden syndrome. A subsequent 2019 paper featuring our own Dr. Sedia looked at the spectrum of gastrointestinal tract pathology of Cowden syndrome. It was a larger cohort of 43 Cowden syndrome patients, 24 of the 29 actually had germline testing, which proved there were PTEN mutations. Interestingly, the majority of the polyps identified in these patients were hamartomatous polyps. And here was the breakdown of what they found, is that of these Cowden syndrome patients, 85% of them had hamartomatous polyps, and followed by that serrated polyps, conventional adenomas, inflammatory type polyps. And so sort of those are more common polyps that you see in every sort of everyday sign out. These hamartomatous polyps, however, were the most common. And what can be seen is this varied histology. So in the top left, you can see is the conventional colonic ganglioneuroma. On the right, you can see, like was pointed out in our differential, is this a neuromatous component to this hamartomatous polyp? And then below that, you can see in the bottom right is this lipomatous component, which was seen in our case. And interestingly, less commonly, the fibrous-rich component at 14%, which was also seen in our case. So S100 was negative in that polyp. However, CD34 would be diffuse and strongly positive. And these polyps, the fibrous-rich component on its own is relatively a nondescript polyp. It's not histologically distinct from the prolapse-type polyps. So it's essential that, identifying this, morphology of a polyp alongside other colonic hamartomatous polyps and sort of other additional history is necessary to make this diagnosis. So again, these were the two colonic hamartomatous polyps that we identified in our case. And on their own, they may not be substantially diagnostic, but in the history of a patient with breast cancer, numerous polyps that show this similar morphology, we were able to suggest that a patient, has Cowden syndrome and should undergo diagnostic testing. So the clinical context in this case is essential. So in conclusion, there is a characteristic admixture of mostly histologically nondescript colonic polyps that are associated with Cowden syndrome. Colonic intramucosal lipoma in the right clinical setting is highly suggestive of Cowden syndrome, and we as pathologists play an essential role in recommending referral to genetic counseling as well as gene testing for our patients. These are my references, and as a special thank you, I'd like to thank Dr. Hart and Dr. Sedia for their mentorship, Dr. Hussein and Dr. Cipriani for being the faculty leads for the IRAP this year, as well as our incoming chief, Dr. Chen, for organizing the IRAP presentations. So with that, I'll take questions.
So any questions or comments on this case?
Yeah, I have a question. It's mostly my lack of knowledge. There was no reason to do STIC11 mutation status, right?
In this case, we didn't. This patient, interestingly, we don't have a large amount of history on her, but the fact that she was a 60-year-old female with these polyps, we were able to suggest that she, despite we didn't have a great top-line diagnosis, but in the comments suggesting that the patient undergo genetic testing, and surely enough, the clinical team agreed and the patient consented to undergo it, but we did not consider STK11 in this case.
So the clinical presentation is quite distinct from Peutz-Jeghers.
Yeah.
Okay.
Any other questions or comments? Okay, Tanner, if you could introduce the next speaker.
Okay, the next speaker will be Dr. Megna Agni, and I think we're going to have to take a second to just switch presentations here, so just bear with us. Desktop. Thank you.
Hi, everyone. My name is Megna, and I'm a second-year resident. I'd like to thank my mentors, Dr. Cipriani and Dr. Pytel. And does anyone know this kid? Does anyone recognize him? He's actually from Chicago, and I'm going to tell you a little bit more about him throughout this presentation. So on to our case. We have a 51-year-old man that presented to an outside hospital with a painful lump on his upper mid-back that grew rapidly over the course of a few weeks, and it became visible through his clothing. He presented to an outside hospital, and they performed imaging, which revealed a large paraspinal soft tissue mass. He also had a core biopsy at that outside hospital, which was reviewed at our hospital, and during that time, he had weight loss, anemia, and fatigue, and the lump continued to increase in size. Imaging at the University of Chicago showed a 5.6 by 4.3 by 3.6 centimeter mid-back paraspinal mass at the T9 to L1 levels. Evidence of underlying hemorrhage and lobulated architecture was present with a mixed solid and cystic pattern. Erosive changes to the T10 spinous process and caudal extension into the left posterior paravertebral musculature was present, lateral to the spinous process. At time of resection at the University of Chicago, there appeared to be cortical destruction and invasion into the spinous processes of T11, T12, and L1. And finally, a diagnosis was made in October of 2020. So a little bit more about our kid from Chicago. He had some hard things happen to him at a young age, but he always had this passion for cooking, and he actually became quite good at it, and he made his way onto Master Chef Junior with Gordon Ramsay, and that made his community very proud. Back to our case. That was a gross image. And here's another gross image on cut section. We see a gray tan rubbery solid surface with a red to mahogany coloring and cystic appearance. And here's the primary excision. You see a well-circumscribed lobulated architecture with the lobules separated by thin fibrous septae and surrounded by dense fibrostroma. There's hemorrhagic spaces apparent on low power, and you also see lymphocytic infiltrates at the periphery. A little bit higher power on those lymphocytic infiltrates, you see that they lack lymph node architecture. And looking a little bit closer at the vascular appearing spaces, you see that they are not lined by endothelium, but rather tumor cells. And the tumor cells are round to ovoid and rather histiocyte-like due to variable amounts of eosinophilic cytoplasm, and indistinct cell borders give it a syncytial appearance. And in general, there are few mitoses and very little nuclear pleomorphism. This is another view that was in the slide that was available for review. Here you see a vascular appearance at low power, but at higher power, we can't make out the cell lining for the blood-filled spaces, and there's extensive fibrin. So I'm going to pause here for a differential diagnosis and actually provide you a summary of all the morphologic features that we saw.
Yes, it's Dariusz Borys from Loyola. Very interesting case. Actually, first I look at the history. So lost weight, fatigue, anemia. So I had a similar case recently, a younger patient, of course. Afterwards, I saw it's like nodular, kind of pseudocapsule formation with this lymphoid component. And also, the cells kind of epithelioid, histiocytic-like with multiple pseudo-angiomatous-like spaces. So while taking all of this, I was thinking about angiomatoid fibroschistocytoma. However, age maybe not. However, there were cases described in older patients. So this was my kind of thinking that AFH could be one of the differential. Of course, molecular will help. Ews R1 positive would confirm the diagnosis, but we probably did some molecular studies as well. So.
Yeah, so we're getting a fair number of differentials. That's the angiomatoid fibrous histiocytoma is definitely leading the pack. And very nice summary by Dr. Borys. Anything else in the differential diagnosis? I think a couple of things. Location, I think maybe epithelioid and PNST should be in the differential, but it doesn't quite fit for that. But I think an important differential consideration, particularly with the location, these ectatic vascular spaces, something in the vascular family of tumors. It's interesting. We have a history of a rapidly growing tumor, but we have a lot of morphology that suggests this thing's been around for a while. We've got, bands of fibrosis. We've got a lobular growth pattern. We've got hemosiderin deposition, et cetera. So could this be something in a more intermediate category of malignancy? I don't know. It looks pretty aggressive, looks big, and looks bad. So probably malignant. Certainly stains might be insightful as well. Did anybody have anything else in the differential diagnosis? One person mentioned pericytic tumor, which I actually briefly entertained because of the relationship of these epithelioid cells to some of the vascular structures. Anything else in the differential by anybody? No? Okay, Megna, that's your cue.
Okay, so just to briefly recap the things that Dr. Boris mentioned very well. Lobular architecture, well circumscribed, surrounded by fibrostroma, peripheral lymphoid infiltrates, blood-filled spaces, ovoid histiocytoid cells with a syncytial appearance, and minimal focal cytologic atypia and mitoses. So to go through our differential, we initially thought of an organizing hemangioma because of the vascular appearance on low power, especially with the fibrin-filled part of the section. Follicular dendritic cell sarcoma because of the histiocytoid appearance, lymph node metastases because of the peripheral lymphoid aggregates, Ewing sarcoma, rhabdomyosarcoma, malignant extrarenal rhabdoid tumor, myoepithelial tumor of soft tissue, and of course, angiomatoid fibrous histiocytoma were all on the differential. We were able to rule out organizing hemangioma because it wasn't lined with endothelium. And then we were left with these entities. So to help us further narrow down the differential, these entities helped guide our IHC selection. And here's a table. I'm going to just highlight some of the main staining patterns. Follicular dendritic cell sarcoma would be negative for Desmond. Ewing sarcoma would be positive for CD99 in a membranous pattern, in a diffuse and membranous pattern. Malignant extrarenal rhabdoid tumor usually shows INI1 loss. Rhabdomyosarcoma is usually positive for Desmond. Angiomatoid fibrous histiocytoma is usually positive for Desmond and can also be positive for EMA. Myoepithelial tumor of soft tissue is positive for EMA and usually S100. And lymph node metastases for carcinoma would be positive for cytokeratins, and for melanoma would be positive for S100 and other melanocytic markers. This is a summary of the biopsy that was done at the outside. The immunohistochemical results of the biopsy showed negativity for all these stains, cytokeratins, SOX10, and SMA. And let's take a look at the stains that we performed. So Desmond was positive in a patchy fashion. So was EMA. CD99 showed diffuse membranous positivity. CD68 was patchy. Calponin was equivocal. And here you see a positive internal control around this vessel. And this is a summary of the immunohistochemical stains so far of the outside biopsy. And then we did GFAP and S100, which were negative. And here are the positive stains that I just showed you. And INI1 was retained and BRG1 was also retained. So back to our differential, with our staining patterns, we were able to rule out follicular dendritic cell sarcoma because it was Desmond negative, because that would be Desmond negative and we had Desmond positivity. Malignant extrarenal rhabdoid tumor because that would show INI loss, and we had INI1 retained. Myoepithelial tumor of lymph node metastases because they would be positive for cytokeratins, S100 and SOX10, and ours was negative. And so that leaves us with these four entities. And we were discussing the morphologic differences between all of these when we got our molecular results. And so the sarcoma fusion NGS panel showed Ews R1 ATF1 fusion, and that helped narrow our differential. Let's talk about tumors with Ews R1 rearrangements. There are a lot of tumors, 17 tumors in fact, with Ews R1 rearrangements, but only 6 of them have an ATF1 fusion partner. And so those are these along with mesothelioma. And that helps us to rule out rhabdomyosarcoma because there's no Ews R1 rearrangement there, and Ewing sarcoma because Ews R1 with ATF1 has not been reported. So to focus again on the tumors that had the Ews R1 ATF1 fusion, this is the whole list. And it's important to mention at this point that had we done Ews R1 break apart FISH, simply detecting the Ews R1 gene rearrangement, it might have led us down the wrong path. And identification of the fusion partner here provided important relevant information, that ATF1 fusion partner. And we will focus on myoepithelial tumor and angiomatoid fibrous histiocytoma from our differential. So to compare these two, on the left, you have angiomatoid fibrous histiocytoma with ovoid cells with pale eosinophilic cytoplasm, ovoid nuclei, a vaguely syncytial appearance, blood-filled pseudoangiomatoid spaces, and a low mitotic index. And on the right, you have myoepithelial tumor of soft tissue, where you have polygonal cells with bright eosinophilic cytoplasm, eccentric nuclei, and a myxoid stromal material is often present. To compare them further, they do often appear in the same locations. They're both deep dermal or tumors of the subcutis and can appear in the head and neck and trunk. But in IHC, there are differences. So EMA is positive, usually with angiomatoid fibrous histiocytoma, but keratins are negative, whereas in myoepithelial tumors of soft tissue, EMA is positive and cytokeratins are usually positive. Desmin is usually positive with angiomatoid fibrous histiocytoma, but it's very infrequently positive in myoepithelial tumors of soft tissue. And S100 is usually negative with angiomatoid fibrous histiocytoma, but it's positive with myoepithelial tumor of soft tissue. Molecular is also helpful. Ews R1 rearrangements with fusions with CREB1 and ATF1 happen very frequently in angiomatoid fibrous histiocytoma. And while Ews R1 rearrangements and other fusions have been documented with myoepithelial tumors of soft tissue, only one case of ATF1 fusion has been reported. And of course, morphology is very important. And while there can be overlaps between the cellular morphology, I've highlighted some things that are different between the two. For example, pseudoangiomatoid spaces are prominent in angiomatoid fibrous histiocytoma. And in myoepithelial tumors of soft tissue, you have an often myxoid stroma, which is rather rare in angiomatoid fibrous histiocytoma. So given the morphology and the clinical picture and the molecular findings, we were able to diagnose this case as angiomatoid fibrous histiocytoma. And to follow up briefly on our patient, he is still alive and doing fine. Extensive wound healing is in progress. However, our Master Chef Jr., whose name is Ben Watkins, was hospitalized with angiomatoid fibrous histiocytoma earlier this summer. So let me tell you more about this tumor. So it was first called angiomatoid malignant fibrous histiocytoma by Enzinger in 1979, but the malignant part was dropped because there's only about a 1% rate of metastases, which are usually local regional. So in general, this tumor has a good prognosis when it's treated with excision. The WHO calls it a neoplasm of intermediate, rarely metastasizing biologic potential, and patients can sometimes present with systemic symptoms like in our case. And there's classic histologic features. It's well circumscribed, lobulated, has a fibrous pseudocapsule. There's prominent lymphoplasmacytic infiltrates around, often called a cuff. There's multilobular growth of ovoid or spindled histiocytoid tumor cells with limited mitoses and sheet-like whorled or fascicular or rarely myxoid patterns. And finally, you have blood-filled pseudoangiomatoid spaces of varying sizes lined by tumor cells. You have 3 characteristic fusions described, and Ews R1 with CREB1 and ATF1 comprise 76% of the cases. And co-expression by Desmin and EMA may help raise suspicion for this entity. Predominantly blue round cell angiomatoid fibrous histiocytomas with CD99 positivity and Desmin positivity should not be confused with Ewing sarcoma and PNET or rhabdomyosarcoma respectively. And molecular helps with this. Unfortunately, Ben Watkins passed away from this tumor. He was one of the unlucky ones, but hopefully his story will help us all remember this tumor.
So any questions or comments on this case? So I have to relay Dr. Taxi's editorial comment, fibrous histiocytoma that's neither fibrous or histiocytic. Yeah, these lesions have suffered from poor terminology historically, I think, but irrespective. Great case. Any other comments or
It's a very good case. AFH is very interesting tumor because, like say, first they thought it was benign, afterwards intermediate. She had a primary bone AFH without other lesions in young patients. But usually you have this history. Clinical history can be helpful with anemia, weight loss, and, temperatures. Very interesting case. And this is actually older patients, so it's very rare in this age group.
Megna, if you could introduce the next speaker.
Yeah, I have the pleasure of introducing Dr. Heather Smith. All right, here we go. That's me. I'm Heather Smith, and I've titled my case If the Tumor Fits, and it's a story of a very interesting brain tumor. With that being said, our patient is a previously healthy 34-year-old male with a history of progressive headaches, nausea, ataxia, and dysarthria that occurred over the course of about 2 months. On neuroexam, he had mild right-sided weakness and dysmetria, and an MRI with and without contrast was performed that showed a very large, diffusely infiltrative lesion that partially effaced the fourth ventricle and showed heterogeneous areas of enhancement upon an administration of contrast. He underwent biopsy and subsequent resection, which showed, here's the intraoperative smear. It shows these markedly pleomorphic cells, which I'm pointing to here. And the low power image of the resection shows this very diffusely infiltrative proliferation of cells that goes throughout the entire cerebellar parenchyma. A closer up view, you can appreciate the cytologic features, which include marked nuclear pleomorphism, hyperchromatic nuclei, and nuclear pseudoinclusions. And while this wasn't wildly proliferative, you could occasionally find mitotic figures like this one over here. And with that, I'd like to take a brief pause so we can discuss a differential diagnosis.
So differential diagnosis of this very cellular, very pleomorphic looking tumor seems to be centered in the cerebellum, perhaps with fourth ventricle involvement, but at least centered in the cerebellum. A couple of differentials that are popping up in the chat include, of course, GBM, and some are mentioning the diffuse midline subtype. Seen, if I remember correctly, disproportionately younger age patients that include the histone family of aberrations. So that's certainly the differential diagnosis. One of the striking things on the piece of tissue that we had for me was the intranuclear inclusions, or pseudo-inclusions. And I'm not a neuropathologist, so I have to preface this comment, but PXA is a lesion. I think the site would be distinctly unusual for that, but PXA is a tumor that in my limited experience does show disproportionate intranuclear inclusions. So I might just add that, right or wrong, to the differential diagnosis. Does anybody have any other thoughts? There's a mention of anaplastic astrocytoma with pyloid features. No? Okay. Heather?
All right.
Yeah.
Those are all excellent thoughts. And our differential diagnosis primarily includes all these astrocytic tumors that I have listed here. These are the current sort of 2016 WHO classification entities. I'm highlighting in yellow the ones that we're most likely considering, as the top few mentions don't have any increase in mitotic activity or cellularity. You could include any flavor of anaplastic astrocytoma. You could certainly talk about glioblastoma, because even though we don't really see any significant necrosis or microvascular proliferation, you don't really need these features in the presence of certain molecular findings. You could also consider pilocytic astrocytoma because of the location. And of course, as you mentioned, the cytologic features, including the nuclear pseudoinclusions and the nuclear pleomorphism, could certainly make you think of pleomorphic xanthoastrocytoma. So with that, let's look at some stains. The tumor cells show strong diffuse immunoreactivity for GFAP, which confirms their glial lineage. IDH1 R132H mutation was negative. ATRX was also negative in the tumor cells, which implies that there could be some mutation there as well. And there was a wild type staining pattern with P53, so you can see a few pale speckled nuclei here and there.
And we also did Ki67, which confirms the presence of mildly increased proliferation. It stains about 8 to 9% nuclei here. Here's a summary of the important molecular features. The main pathogenic findings include loss of CDKN2A and mutations in both NF1 and ATRX. Pertinent negatives include that there was no mutation whatsoever in any IDH1 pathway, no mutation in BRAF, and no abnormalities in EGFR or the TERT promoter. MGMT promoter methylation was also absent. I'd also like to draw your attention to this copy number variant plot in order to show you a couple of other pertinent negatives, which is that we don't really see any gain of chromosome 7, and we also don't see loss of chromosome 10. So where exactly does that leave our differential diagnosis? We thought about an IDH mutant anaplastic astrocytoma primarily because of the patient's age. These do tend to occur in patients who are under the age of 50. However, they're almost always hemispheric. And by definition, IDH 1 or 2 mutations are required for diagnosis, so that's out. Could we therefore be looking at anaplastic astrocytoma or GBM IDH wild type? Well, he's a little young for that, seeing that he's 34 years old. These are also nearly always hemispheric. And even though necrosis and microvascular proliferation aren't technically required in the presence of certain genetic abnormalities, we don't happen to have any of those genetic abnormalities, so that's out. Could we still be looking at a pilocytic astrocytoma? The location's pretty good for it, but it lacks the classic morphologic appearance. And it also notably is way too infiltrative for that to be considered. And it also lacks the BRAF-KIA 1549 fusion that you see in the posterior fossa variant of this lesion. So that is out. Could we still be looking at a pleomorphic xanthoastrocytoma? Posterior fossa is a little bit unusual, but these can occur technically at any location. And the nuclear pleomorphism and the CDKN2A loss actually could support this diagnosis. However, these almost always have a BRAF V600E mutation, which this lesion does not. So that too is sort of out. So what in the world could we be looking at then? And what do we do when the current WHO classification scheme leaves us cold? We go to the literature and we see a study from the University of Heidelberg in which they retrospectively looked at 102 lesions that were classified as pilocytic astrocytoma with anaplasia, and they characterized a previously uncharacterized lesion that they called anaplastic astrocytoma with piloid features. And you can see just from the title of this paper that there are genetic abnormalities present in these lesions that also are present in our patient, including alterations in the MAP kinase pathway, CDKN2A, and ATRX. GNA methylation profiling is increasingly used in CNS tumors, both for diagnosis and for characterizing new lesions. And they looked at the methylome. They looked at the methylation profile of these 102 different lesions that were originally classified as pilocytic astrocytoma with anaplasia. And they're all plotted in black as black dots here on this PCA plot. And they form their own distinct cluster that is fairly far away from both pilocytic astrocytoma, notably extremely far away from the posterior fossa variant, also pretty far away from PXA, and also reasonably far away from many of the glioblastoma variants. Clinical characteristics were looked at, and the vast majority of these lesions occur in the posterior fossa, as was the case for our patient, with the remainder occurring either in the hemisphere or in the spine. These can occur at any age, but they most commonly occur anywhere from like young adulthood to middle age, and our patient, being 34 years old, falls right in the middle of this peak. The microscopic features show considerable variability, with about 40% looking a lot like pilocytic astrocytoma, and an additional 40 or so % looking a lot like GBM. But 10 to 12% are at least focally PXA-like, like our lesion. More consistent features include moderate to high cellularity, some degree of nuclear pleomorphism, and a diffuse infiltration pattern. Next-gen sequencing was also done on these lesions when available, and the most common genetic alterations are anything in the MAP kinase pathway, which covers about 75% of the tumors. Alterations in CDK and 2A or B, which includes 80% of the tumors, and ATRX loss or mutation, which includes 45% of the tumors. And notably, 30% of these tumors have NF1 mutations like our patient did. The Kaplan-Meier, the survival times of these patients are plotted on this Kaplan-Meier survival curve, and anaplastic astrocytoma with pyloid features is shown here in black, and the survival time is fairly similar to that of GBM with the IDH mutant GBM, and it's considerably worse than either pilocytic astrocytoma, but still considerably better than the conventional IDH wild type glioma. And now would be a good time to mention that our patient did have a recurrence 10 months after the original diagnosis and had a subsequent resection.
Did you see the bus?
He had a subsequent resection and is now following up with a neuro-oncologist. So since the 2016 edition of the WHO classification of CNS tumors, we've had 7 updates. And in one of the more recent updates, CIMPACT Now 6, which was published back in April of 2020, they've decided to include this entity, which they're now calling high-grade astrocytoma with pyloid features, in order to avoid confusion with conventional anaplastic astrocytoma. With the caveat being listed that not all of these really have pyloid features. In fact, a lot of them don't really look very much like pilocytic astrocytoma. And there is quite a bit of variability in the morphology. I'd also like to point out some other inclusions, being the G34 mutant glioma, which we showed a case of last year, and some new genetic features that are sufficient for the diagnosis of GBM, including gain of chromosome 7, loss of chromosome 10, and EGFR TERT promoter mutations. And generally speaking, molecular testing and profiling have changed the diagnosis of CNS tumors so much and have created the discovery of so many other lesions that when all else fails, when nothing seems to fit, if you search the literature, you might just find something that does. So with that, our final diagnosis did indeed wind up being high-grade astrocytoma with pyloid features, which, to summarize, is a recently defined entity with a very distinct methylome that's proposed to be included in the next WHO classification that'll be coming out later this year. It has a predilection for the posterior fossa of middle-aged adults. It shows considerable morphologic overlap with pilocytic astrocytoma, GBM, and PXA. And the most common genetic features include MAP kinase pathway alterations, CDK and 2A loss, and ATRX mutations. And while more studies are needed to establish a grade, the prognosis is generally similar to IDH mutant glioblastoma, which is to say, aggressive, but somewhat less so than the IDH wild type gliomas. So with that, I'd like to thank my mentor, Dr. Pytel, and take any of your questions.
Yeah, Heather, thank you. So are these going to be WHO 3s or 4s?
Oh, that I don't know yet. Even in the CIMPACT Now 6, they mentioned that there weren't really enough studies yet to establish any sort of grade, but I think that they're probably going to be listed with the 3s.
Yeah, maybe 3 1/4, maybe?
Maybe so, 3.25, 3.5, I don't know, somewhere.
So do you guys do these methylation studies on all your high-grade glial tumors, or just the ones that are difficult to readily classify?
I don't think we do that here. I think it's more just done on the ones that are hard to classify. But I could also defer to Dr. Pytel if he's here.
It really seems like you know, the rest of the world does these methylation profiles. I think based on comments at past IRAP meetings, I think the U.S. is a little behind on doing that routinely. So it's like you alluded to, I think it's the future of assessing these tumors, is these methylation profiles, and see exactly where these tumors tease out. Are there any other questions or comments? I'm kind of looking through the chats. Not really. I just want to congratulate everybody on terrific cases, terrific job. If you would like CME, please make sure that you put your chat or answer to the chat. Make sure your name is there so that you properly get CME. And just a housekeeping item, there's no conflict of interests. And I mentioned that in the context of filling out the evaluation form. So if you do get a chance, please fill out that form. That's very useful to us. Without further ado, again, thank you, U of C, for a terrific job.
Yeah, thank you. Great presentations, residents. We had, I think, a record-breaking attendance this time. The max I saw was about 178 people had signed in. So that's really nice. I also want to get some feedback from people about their thought about sending out that PAC presenter link. We are thinking that in the future, people who want the IRAP glass slides should be able to subscribe to that and get glass slides, and then others can then look at them virtually if they want. So there are some things coming up for presenters, especially for trainees. That's right. If you're not subscribing to the, oh, good. And I'm glad that the link worked. Great. Okay, good. Thank you. See you next time. Thanks, Mike.
Thank you for sharing good cases.
Yeah.